Good morning, everybody. Good afternoon, good evening in India. I am very excited to present today our last session of the Johns Hopkins University Rise India COVID-19 webinar series. This series was always intended to be very high level. And the reason for that is one of the challenges of COVID-19 has been the plethora of misinformation, right? Or too much information, to be honest. And so, individuals struggle with like, what is the right answer here? What should I be looking at for treatment? And so what we thought as Rise India was to bring together experts from both India and Johns Hopkins University to synthesize the evidence, to give the healthcare workers here who are on the front line, actively caring for patients under extremely stressful situations, easy access to information. So at the end of today's series, I will also share with you where you can find recordings of previous sessions that you may have missed. And I will also be able to share with you our resources moving forward. So just to get us started, I'm going to give you the agenda right here. And so I'll start off with a brief introduction. We're going to have an inaugural address by our colleagues at USCID and a keynote address from Nimhans Bangalore. We'll have a case presentation that is led by Dr. Sydney and Dr. Naveen Kumar. And then we'll have a panel discussion. We also then will end with an evidence-based review. So we'll start off this session talking about the mental health complications and the management of mentally ill individuals with COVID. But we're going to end this session focused on you as the healthcare workers and what you can do for your own mental well-being. And then at the end, I will share a QR code to take you to our website, which showcases all of our resources. So let's get started. First of all, I want to thank our gracious host, Nimhans Bangalore. And I want to invite Dr. Pratima Murthy to please start this auspicious session. Dr. Murthy, are you able to unmute?
Hi, can you hear me?
Yes, ma'am.
Yeah. Hi, good evening, everybody. Good morning, wherever you are. I just wanted to say I'm on the road and of course it's raining. So pardon me if the audio and the video are pretty blurred. It's very exciting to be here today because so far when we talk about the COVID pandemic, we've been talking mainly about the mental health consequences. We've been talking about managing persons with severe mental illness. And of course, we've been talking about the mental health of healthcare workers. But I think today is a very unique day where we're going to actually discuss cases, and the way we've managed them. Nimhans has been, in some ways privileged to be able to have had the experience, although we're not in a COVID hospital. We've been managing patients who had mental illness along with COVID, and we've kind of on the go evolved strategies, both in terms of testing patients for COVID, managing them, in situations where patients have been in dormitories and therefore at risk to COVID when one of the other patients gets COVID. Reasonably successfully managed those with COVID-19, and most importantly, I think prevented the pandemic from the infection from spreading to other patients with severe mental illness, particularly those with comorbidities. So I think there are a lot of lessons to learn. My colleague Sydney has been in charge of the COVID facilities that we've set up. We divided the hospital into a red zone, which had patients with suspected COVID or COVID indeed, and therefore I think the experiential aspect of it is going to really help the viewers understand what it is that we were able to do, what were the challenges, and how we managed to overcome it. So I'm not going to stand between you and the presenter. Again, very exciting seminar ahead of you, as well as a panel discussion following the case discussion. So I hope you all enjoy this academic feast ahead. Thank you very much.
Thank you, Dr. Murthy. And I have to say, surprisingly good sound considering you're on the road. You must tell us your secrets. Next, I want to introduce the Jhpiego India team. So for those of you who have not met these amazing individuals, Dr. Bulbul Sood, our strategic advisor, Dr. Somesh Kumar, country director for Jhpiego India, and Dr. Vineet Srivastava, who is our chief of party for the RISE project. They've been working tirelessly across the seas to develop a pan-India approach, meeting with heads of state, meeting with individuals at health facilities, individual healthcare workers to understand how best can Jhpiego and the RISE project in particular support India, not only during the acute COVID-19 pandemic, but also to build further resilience at the health systems level against pandemic response. We are also joined by our USAID India mission team. So the activities of the RISE project are funded by the United States Agency for International Development. And the USAID India mission team has been in the background championing different actors, advocating for innovations, identifying both public and private sector partnerships on which to leverage this program. So I would like to invite Mr. Vijay Polraj to not only welcome all the audience here today, but also to introduce these colleagues on the slide. Vijay, are you available? Surendra, are you able to confirm? I'm unfortunately not able to see my chat.
I think Vijay is not on the call today, so maybe we can continue, and if he joins, we can stop midway.
Okie dokie. So let me take a moment just to really thank our USAID mission colleagues. Sangeeta Patel, Amit Shah, Cynthia Gear, and Vijay Paul have been up and down the country visiting health facilities. Many of you may have met them. They really championed not only the activities but the needs of the healthcare workers across India managing COVID-19 patients. And lastly, I want to just thank some of my colleagues here at Johns Hopkins University. Dr. Laura Murray will be our speaker today, but in the background, there is Dr. Valerie Asula, Pavna Seth, and Sobek Chatterjee, and we have been working on creating an easy to access set of resources that you can take away from each session. And last but not least, today's colleagues from India. You'll hear shortly from Dr. Naveen Kumar and Dr. Sydney, who will present the case and the discussion around COVID-19 management. And then we'll also be joined by Dr. Janarthan Reddy and Dr. Rajni Parsathi in the panel discussion, and who will answer some of the questions on COVID-19 management for COVID-19 management considerations and mental health. And last but not least, who are you? So, we had over 300 individuals participate or register. The majority of individuals are physicians. We have great representation from all 23 states, with the highest representation today from Andhra Pradesh. So welcome to all of you. As I said, we have twofold objectives here. The first being the management of mentally unwell individuals who also have concurrent COVID-19 illness. And the second part of this presentation, led by Dr. Murray, will be on you, the healthcare workers, who are working extremely hard to manage COVID-19 patients. So, Dr. Sydney, can I please pass over to you? And please just say next slide when you're ready to move on.
Thank you very much, Dr. Bhakti. Good morning and good evening, everyone. It has been really an honor to be here with everybody in this seminar. When we thought we'll present a slide with mental illness and COVID, then I thought what would be the most appropriate or something which gets our attention, what mental illness would be like that. I mean, throughout the course of the discussion, I think most of us must have heard about anxiety, about depression, so many things associated when there is a pandemic. Then I thought no, why don't we discuss something little different, which now is a controversy or rather a raising topic as we understand this virus more as the time progress. So today I'm going to present about catatonia and COVID. All right. So what exactly is catatonia? For us in the mental health profession, catatonia is always akin to an emergency. I mean, where people can progress from mild evolving catatonia to very fatal unless treated. Of course, this was historically. Things are much better now. So the catatonia is basically defined as a psychomotor anomalies which can arise in the context of mental illness like schizophrenia, schizoaffective disorder, or mood disorder generally. And few things which characterizes catatonia as we understand it today is when a person is mute, he's not responding, or he's just doing just that is what is called negativism or ambitendency, stereotypic posturing. So these are some of the symptoms which broadly falls under what we understand catatonia as a syndrome or catatonia as a subunit, or maybe as a presentation. The presence of 2 or 3, depending on what classificatory system we use, we say that catatonia is present and it needs to be treated. What are the risks? Yeah, the risks are, it can lead to malnutrition, it can lead to death unless treated, and metabolic disturbances. Next slide, please. Yeah. So why are we presenting it today? Okay, when we started to understand the COVID virus last year in 2020, it is a new thing. We are medical professional, but it's new. I mean, we really don't know much about it except for the background of it belongs to a subtype of coronaviruses. The concern which we had in our mind is that, yeah, the lungs are affected. There is a cytokine storm that causes a lot of mortality, morbidity and mortality. When we talk about the respiratory system, which is the target for the COVID, that is where it exactly challenges, or it becomes a huge challenge in the management of catatonia. We use in psychiatry antipsychotic drugs, particularly benzodiazepines, because a higher dose of benzodiazepine always carries the risk of a respiratory depression. So if you're using a medicine which increases the risk of respiratory depression in a person with maybe a compromised lungs, then those are the times we need to think over. Then there was concern with the use of electroconvulsive therapy, or what is known as the ECT, under anesthesia. ECT causes or does anything to an already infected individual with COVID, but it is about the concern of aerosol spread of viruses when a patient is anesthetized or is under anesthesia when you are giving the therapy. So these are some of the challenges which we had faced regarding this particular case. Can you go to the next? Yeah, so let me just start with this particular case that we are going to discuss. So we had a 35-year-old lady who came last year to our psychiatric emergencies with 1 month duration characterized by sadness, loss of interest, anergia, then decreased confidence, lack of appetite, insomnia, and social withdrawal, just in the beginning. Then 4 days prior to hospitalization, that is where the catatonic symptoms unfolded. She had what is known as stupor, negativism, mutism, posturing, staring, Gegenhalten, and withdrawal. Gegenhalten is if you ask the patient, can you just raise your hand, and you're trying to raise the limb with a little bit of a pressure, the patient will oppose it with a directly proportional pressure or force in the other direction. So it is one of the symptoms. Okay. So this was the presenting symptoms that brought her to our psychiatric emergency as a patient with acute catatonia. She had comorbid hypothyroidism, which was on treatment with replacement thyroxine. There was no history of any other comorbidities or history of any substance abuse. As is quite common with a lot of patients with mental illness, she has been off drugs for the past 5 to 6 months. So she had a relapse when there was a drug default. Next slide, please. So what exactly was she suffering from? She's suffering from a very severe mental illness, what is known as a schizoaffective disorder. When we say schizoaffective, it is the depressive subtype. So she had trials of medicines like risperidone, olanzapine, amisulpride, ariprazole, chlorpromazine, and multiple antidepressants, pretty much everything over the past 15 years. And according to the treatment record that was available at that time with us, she was given clozapine, which we usually keep it as a reserve drug when nothing else pretty much works. So, I mean, it's just like, the only thing which you feel will do something to the patient. Yes, it really did give her some benefits, but she had side effects like excessive sedation, weight gain, and constipation, and then it was stopped. Ultimately, was given a combination of quetiapine and sertraline, and she had some degree of benefits in the past. There was also history that she responded to ECT. 3 courses had been given over the past for an event of suicidality. It is understandable when you say schizoaffective disorder and a depressive type, then you also expect suicidality as an indication of severity or as a part of the illness. However, she doesn't have any symptoms of catatonia in the past. Next slide, please. Before we admit or before we try to do anything for it, we just try to understand how severe is or what exactly is the patient in terms of catatonia. The Bruce Francis rating scale for catatonia is a commonly used instrument by mental health professionals across the globe. So here also we use it, the original version. And if a patient scores more than 2 or 3, depending on this version you're using, we say that it's catatonic. So she scored 18, which is fairly moderate to severe. Yes, COVID had already started, and it was mandatory in our hospital that if you are going to admit a patient services or to have an inpatient treatment, then it has to be amended. An RT-PCR for COVID has to be done. So that is where she tested positive. Till this point of time, there was no influenza-like illness symptom reported with her. Next slide, please. So why it is unique in our facility? NIMHANS, we are probably one of the biggest mental or neurosciences facility in the whole of Southeast Asia, but we don't have the luxury to be backed by a strong medical unit. And most of the management has to be done by us. There is also a unique challenge that when you refer patient or when we refer patient to a dedicated COVID center, and many of them are not usually equipped to handle a mentally ill. So most of our patients has to be sent back. Then from a disease perspective or from a patient's perspective, many of the mentally ill, they have problems in behavior and comprehension. So when you have to follow a COVID protocol, then there is a special challenge that, like, adherence to safety protocols, poor communication, difficulty in managing. So these are some of the challenges. And to minimize the spread of infection, like our director has said in the beginning, we started a separate facility in our hospital campus. The management of COVID in India has been fluidic, like everywhere else in the world. We upgrade our guidelines from time to time, and very often we follow our own guideline, which will be closely paralleling the Government of India one, the one which is followed by the NIS and other agencies where we feel deemed it will be suitable for the patient. Next slide, please. So let me just go through how we have managed to treat the catatonia. So usually, like I said in the beginning, we use lorazepam as one of the benzodiazepines and did pretty well. And since he had responded in the past with sertraline and quetiapine, it was reinitiated. Any case of catatonia, the first thing here in our setup is what is the best way or the quickest way to make the patient come out of catatonia. That is where we use either a fairly high dose of lorazepam, what is known as the lorazepam trial, or if it is responding, then let's use ECT. So initially, we started with the lorazepam trial. It had resolved, but some of the symptoms persisted. So that is when we started the bifrontal ECT, 7 sessions given, and gradually improved. Thankfully, there was no decline in the respiratory function because lorazepam was used or any other systemic pieces of COVID were noted. In 10 days, the patient got better. And according to the main date, when she does not have any symptom of COVID, she was transferred to the adult unit, and the lorazepam continued to be given, but in a tapering dose, and we stopped it over the next 2 weeks. The patient was subsequently discharged. Next slide, please. Can we go one slide further, please? I think we missed one.
Sorry, Sydney, I'd move straight onto the discussion slides. If you want to just verbally mention that standard treatment for COVID was provided.
Yeah, so initially what we did is, I'm sorry, I was not aware of the time. By the protocol of that particular time, the patient comes under what is known as a mild or a mild symptomatic COVID. The serum markers were not very high, and we have started what was the standard protocol then. It consists of, contrary to what happens in the US or the UK, we started with ivermectin, we started with tetracycline, then we give supportive treatment like vitamin B, zinc, and some other. And antihistaminics if there are any symptoms of that. So there has been no progression. Most of the immune markers were normal, and that is how we have treated her COVID. What is the point, take-off point here? Treatment of catatonia has always been a challenge, and why is catatonia happening is where we need to be more focused. Catatonia to us is a manifestation of a psychiatric disorder, but what seems to be catatonia can also be symptoms of, or would look like symptoms of other illnesses, like even like a severe Parkinson. And what is causing catatonia? There are a lot of hypotheses, but some of the recent work also suggests that it might be linked to infection and immune dysregulation. And basically, catatonia is an acute response to the earlier part of maybe an infection. And when some studies were done, it was also found that the inflammatory marker which we use for COVID, like D-dimer, C-reactive protein, and serum ferritin, are also mildly raised in patients with catatonia without a COVID as well. So that is why we need to be a little bit mindful. How does COVID enter? We already know. I mean, it can be in hematogenous spread from the brain via the olfactory plate, and it can have multiple presentations ranging from a mild headache, loss of smell, to encephalopathies, to palsies, and catatonia. Next slide, please. So that is again where the uniqueness of this particular case is either because we have managed the COVID or the catatonia was managed, or either because of both reasons, there was no elevation of immune markers throughout the entire course of the illness. There was a stable course of a COVID infection. Contrary to the popular opinion, or rather the fear or the misgiving, because this thing is new, we have demonstrated very safe use of benzodiazepines, and respiratory depression was not encountered at any point of time for this patient. What could have been responsible, this is more like a hypothesis, and some work are going on, is ill when they are given a fairly good dose of antipsychotics, the most studied being chlorpromazine, it probably prevents the docking of the COVID virus on the ACE2 receptor, and that might be responsible for some lesser symptoms, but this is subjected to a lot of data which we can't really say at this point of time. Next slide. And for the medical community, why it is important? Because what looks like the manifestation of a psychiatric illness could also be a manifestation, rather the neuropsychiatric manifestation of COVID. And here, the whole rationale is, yes, there will be challenges because they are mentally ill. The assessment will be difficult. You cannot separate mutism from catatonia from like a mutism because of severe Parkinsonism or diseases like that. But it should not hold us, and there should be a judicious use of parenteral benzodiazepines, and ECT should be, whenever it is required, it can be safely used. So this is basically what I want to demonstrate in this particular case.